Welcome everyone to tonight's Fertility Network UK webinar on the referral pathway for NHS fertility treatment in Wales. My name is Bethan, my pronouns are she, her, and I work for Fertility Network UK, providing support to people on a fertility journey. To let you know, this session is being recorded. She'll be able to watch it back as we'll share it on our YouTube channel. But for reassurance, we can only see and we're only recording the speakers. Please do ask any questions you want on the topic. Just submit them in the Q&A function and we'll get through as many as we can at the end of the presentation. So without further ado, let's begin tonight's session on unexplained infertility. Tonight's session on the referral pathway for NHS fertility treatment in Wales. I'm delighted to be joined by Dr Meera Ramcharn, and she is the consultant in obstetrics and gynecology for Cardiff and Vale Health Board. Welcome, Meera, and over to you.
Oh, thank you so much, Bethan. So I'll just share my screen. How's that?
Perfect, thank you.
Yeah, perfect. Okay. So thanks for the introduction, Bethan. So what we will be talking about tonight is the NHS referral pathway, essentially from when you see your GP to if you do eventually need IVF, and all the bits in between. So this will apply to heterosexual couples, same-sex couples, or single people in their fertility journey. As Bethan said, I work in Cardiff and Vale Health Board, but generally speaking, most of the things I'll be talking about should be applicable throughout all of the health boards in Wales, and there are policies to make it equal, no matter where you live, basically, to eliminate any sort of postcode lottery. As I've said, we'll be starting with what happens when you go to see your GP, what would happen if you came to see me in the hospital, what investigations we would recommend and why we do that, a little bit about the referral criteria that you would need to meet to be eligible to have assisted reproductive treatment on the NHS, a little bit about WFI, which is the NHS Wales ART unit, and then I'll welcome any questions, any clarifications, any comments. So a little bit about me. As Bethan said, I'm a consultant in obstetrics and gynecology in Cardiff and Vale. I've got a special interest in fertility and paediatric gynecology, and I run the fertility clinic with a colleague in Cardiff. I also worked for 8 months at WFI last year. So I know all about the running processes and what you can expect there, so I can talk a little bit about that as well. And the main thing I wanted to reiterate is that I've got no conflicts of interest when I'm providing this talk today. I won't be able to provide any personalised medical advice to anyone, but we will be able to talk generally through clinical scenarios. So probably most of the people that are attending today on this webinar are either at the start of their fertility journey or waiting to be seen. Generally speaking, it's thought that about 80% of couples who are having regular and protected sexual intercourse will conceive, so have a pregnancy within 1 year, and the remaining 20% will conceive within the 2nd year. So within 2 years, 90% of couples in the general population will have a pregnancy. We would recommend, and NICE as well, that you would seek support and help from your GP along with your partner if applicable after about 6 to 12 months of regular unprotected sexual intercourse, just to have a checkup, and I'll talk about what you can expect when you go to see the GP now. So Your GP, or as it's known as primary care, will perform an initial consultation with you. Generally speaking, they will go through a few questions with you, which will include if you've had any pregnancies before. They'll want to know about your menstrual cycle. Is it heavy, painful? Is it regular? If you've got any medical problems, if you're taking any medications at the moment, that sort of thing. They'll also talk a little bit more about your lifestyle. So if you are drinking alcohol, and to limit that, the national guidance is to 1 to 2 units of alcohol a week for women, and 3 to 4 for men. Support with smoking cessation if that's applicable to you. Support with BMI as well, and whether that would be in terms of accessing NHS eligibility for services, or I'll go on to talk about that a little bit later on. Checking your cervical smears are up to date and that you're taking the recommended preconceptional vitamins, so for example, folic acid. When you're there, I'd also expect them to organise some routine investigations. So this would include correctly timed hormonal tests, and that's timed throughout your menstrual cycle. So I've just got a graph here, and you can see the different colours are your different fertility hormones, and you can see the levels of them go up and down throughout your menstrual cycle. And that's why it's important that when we test your fertility hormones, it's done at the correct time. So we would expect that you would have a blood test between the 2nd and 5th day after you start your period, and then roughly 21 to 28 days after you start your period as well, to give the most accurate results. Depending on what you've revealed in the initial consultation, your GP may also order a pelvic ultrasound to look in a bit more detail at your ovaries, your tubes, and your womb itself, and a semen analysis for a male partner as well, if applicable. And that's really helpful to get before we see you in the hospital, just so we're not delaying anything there. Generally speaking, after you've seen your GP, and if you still haven't conceived, a routine referral. So if you've been trying to conceive for 1 year, you're less than 35 years old, and the initial investigations have been normal. Or you would be referred more urgently if the woman is over 35, if any of the investigations have returned with something we need to look into in a bit more detail. So, for example, a significant change in what we'd expect to see in the semen analysis, any known medical disorders like severe endometriosis, and that would apply if you've been trying to conceive for over 6 months. Generally speaking. So when you get to the hospital, so for example, if you were referred in Cardiff, you would either see myself, my consultant colleague, we've got a really experienced nurse specialist, or one of our junior doctors in our team, who would be supervised by a consultant. Here we would reconfirm all of the medical details, so it might seem a little bit repetitive, but it's just to check that nothing's been missed. We check all your results. Extra things that we would do in the hospital, if required, would be tests to check that your fallopian tubes are functioning well and they're open. So essentially the role of your fallopian tubes is allow the sperm and the egg to meet. And how we perform that test in Cardiff is a special X-ray test called a HSG, and I've just included a photo of this here, where it's a little bit like a cervical smear, where dye is inserted through the neck of the womb. We do a special X-ray just to check that the dye spills out through the tubes and that there's no damage or injury to the tubes. We can also look into ovulation testing. Usually we do that through a blood test. And again, it's just making sure we do that at the right point throughout your menstrual cycle. If you haven't had a pelvic ultrasound before, or if we need to double check anything, we can do that for you in clinic if indicated, or we can order that for you. And if we've got any concerns on the pelvic ultrasound or from any of the questions that you've been asked, we can also organise some extra investigations in terms of a keyhole operation or a laparoscopy, to look if there is any scar tissue or any evidence of endometriosis within your pelvis or your tummy. And we can also organise some camera procedures where a camera is passed through the vagina, in through the neck of the womb, just to inspect the inside of the womb and see if there are any concerns there. If you haven't had a semen analysis yet, we can order that for you, or if there have been any abnormalities, we can repeat that for you as well. The treatment we would offer in the hospital would be if you either weren't ovulating or you weren't ovulating consistently. There are medications that we can prescribe. Some of these you might have heard of. So we prescribe clomiphene or Clomid, letrozole and metformin, and we also monitor those medications to check that they are being used safely and effectively, either in forms of blood tests or ultrasound scans. We also provide weight loss support. So that can be for a number of reasons. So whether that is to reduce the risks in surgery or anaesthetic risks if a operation has been recommended. Sometimes if the BMI is raised, just a 5% reduction in weight can cause women to ovulate on their own again without the need for medicine. And we are also well supported by a good team of dietitians as well, which is great. And we also perform the operations. So usually within the fertility services, I would perform these for you. So we've got our as I've said, our keyhole or our laparoscopic operations. And then I've put a picture of one of our camera operations, which is known as a hysteroscopy. So here, this is a picture of inside the womb, and you can see this kind of spherical structure inside the womb is a fibroid, which is growing where a baby would grow. So I can remove that for you. And then depending on the situation, either try to conceive on their own for a little while or refer for IVF. Depending on the results of the investigations and the treatments that we've tried, it may be at that point that we would recommend a referral for assisted conception therapies. And just a few examples here I've listed. So, for example, if you had significant problems with your fallopian tubes, which we've picked up on a operation or on the special dye X-ray test, the HSG, if there are significant concerns with the semen analysis, if we've either diagnosed or you're known to have moderate to severe endometriosis, and if you've been trying to conceive for 2 years, we've done all of the investigations and they've all come back as normal, that would be consistent with what we call a diagnosis of unexplained subfertility. And we would offer IVF at that point. So I'm going to speak a little bit now about the referral criteria, which applies if you are hoping to have NHS funded ART. It's quite a strict criteria, so I'll go through the different parts of that, and usually this is the part of the consultation that people are most interested in, and the criteria is available online. This criteria has been put together by a committee called WISC, who you may not have heard of, but essentially WISC stands for the Welsh Health Specialised Services Committee, and their role basically is to plan and coordinate the specialist services throughout the whole of Wales, such as ART, to ensure that no matter where you are in Wales, you'll be provided with the same good quality standard of care. So the first criteria for NHS referral would be age. So the minimum age for a woman would be 20 and the maximum would be 42. If the woman is 40 to 42, She would also need to have not had any previous IVF treatment, no evidence of what we call low ovarian reserve. So that is something we would check with those hormonal blood tests that I was speaking about before. So the blood test we would check is a hormone called FSH at the beginning of your cycle, AMH, which you might have heard of, and also a rough count on a ultrasound of the ovaries, of how many eggs or follicles there are. And also we would be having and documenting a discussion with you about the associated risks with having IVF in a pregnancy at this stage. For males, the age is less than 55. In terms of existing children, if one of the couple does not have a biological or an adopted child, they can be referred. So if you've had a child together already, you wouldn't be eligible for NHS treatment. Or if the couple had both had children separately, again, they wouldn't be eligible. And if a single person is hoping to be referred, again, it would be no biological or adopted children. In terms of BMI, the BMI criteria for female patients is 19 to 30. I've popped a little asterisk by 19. So if the woman's BMI is less than 19, but we've got evidence that she's ovulating regularly, because that can be affected by a person's weight, they can be referred. And then they've said for men, ideally less than 30 as well. All patients need to be non-smokers, so we can't refer you if you're smoking, and when you are reviewed in WFI, one of the first things you will do is have a carbon monoxide test for smoking, and unfortunately if that's positive, your treatment will be halted at that point, and reassessed. In terms of undergoing previous fertility treatment, which I think is really important, because some patients come to see me in clinic and they've undergone previous private IVF treatment, either here or abroad. If you've had more than 3 cycles, unfortunately, you wouldn't be eligible. And if you've had any cycles and you're over the age of 40, again, you wouldn't be eligible then for NHS funded treatment. So, spoken a lot about WFI, that is the Wales Fertility Institute. As of a few months ago, that is solely based in Neath Port Talbot, and they provide ART services basically for the whole of South Wales and the surrounding region. I've only worked at WFI and we only refer there. But for Mid Wales, I believe you've got the option of being referred to Shrewsbury and Telford in England, and for North Wales, the Liverpool unit there. So within WFI, the treatments that you would be offered include IVF, so in vitro fertilisation, where the eggs and the sperm are left to fertilise on their own, hopefully make some embryos, and then transfer an embryo back. ICSI, which is what the picture here you can see, so that stands for intracytoplasmic sperm injection. So that's when the best sperms basically are chosen by the embryologist and injected directly into the egg, again, hopefully to make some embryos, or IUI, which is intrauterine insemination. So that would be for heterosexual couples who have a normal semen analysis. That would be for same-sex female couples or single women, and that would be with a sperm donor, if appropriate. If a male patient had any abnormalities in their sperm, we may ask them to see a urologist, and it may be appropriate for them to have a minor operation, basically, to try and gain some sperm, which is a bit of a better quality. I've spoken a little bit about donor sperm. So there is a donor sperm bank which can be accessed for free via WFI. Unfortunately, and as I believe is the case in nearly all of the NHS units, there aren't any donor egg banks. So if you were hoping to have treatment with a donor egg, that would need to be either self-funded or with a someone you know, so a friend or a family member, if again they fit quite strict criteria. And we also see patients or couples for surrogacy as well. And again, that's under, there's quite strict criteria with that. Okay, so you're referred to WFI. They aim to see all referrals within 26 weeks, so just over 6 months. So really the aim of when I see you in clinic in the hospital is to do all of these investigations, so that when you get to WFI, you don't need to be referred back and need any operations or any extra investigations. A urgent referral will be made if, for example, the woman is over 36, if we know the woman has any severe endometriosis. Another example would be if on a semen analysis we weren't able to see any sperm cells. Those are the sorts of urgent criteria we would see. When you get to WFI, what will you be offered? So generally speaking, if a woman or a couple is under the age of 40 years, they would be offered, as long as they meet the rest of the criteria, 2 full cycles of IVF or ICSI. So that would include the stimulation of the eggs in the ovaries, and then hopefully any embryos that would be made, and any embryos that would be replaced, so whether they would be fresh or frozen and transferred back at a later date. If the woman is between 40 to 42 years, she would be eligible for 1 full cycle. But again, there are these 3 caveats to that, that the woman can't have had any previous IVF treatment. There's no concerns about limited ovarian reserve, and the woman's aware of the risks associated with IVF and pregnancy. So those are just my references there. I know that was just a very brief overview of the fertility pathway. So I'm happy to go over anything again, answer any questions, or take any feedback on board. Thank you very much for listening. And of course, thank you again to Bethan for asking me to speak again and for organising this. Thank you.
Dr. Ramcharn, thank you so much. That was really, really good, really in depth. And I've got no doubt it'll really help people, because I think what we know is that lack of information sometimes can cause sort of a lot of like worry for people. So thank you. Thank you for sharing your expertise and your knowledge in such a compassionate way as well. We're really grateful. Quite a few questions have come through, so I'll read them out if that's okay. So the first one we have then, would it be worth starting to take folic acid now if you are starting the fertility journey?
Yes, sorry. So that's something I should have clarified. So generally we advised taking folic acid 1 month before trying to conceive. So yeah, absolutely now. There's no harm with folic acid. There are a few groups who we advise taking higher doses of folic acid. So your GP can support you with that. But one of the examples would be, for example, if you had diabetes or epilepsy, we'd recommend a higher dose of folic acid. So if you've got any concerns with that, you can always go and see your GP for a bit of clarification.
Thank you. The next question then. Hi, and thank you for this evening. I'm 40 and trying to conceive for 2 years. My GP has done the initial test you mentioned and has said unexplained primary infertility. Due to my age, is NHS an option, or do I need to seek private treatment? Thank you.
So, from the information you've given me so far, if you don't have any children already, we would be happy to see you as a urgent referral in the fertility clinic. And even if eventually you're not eligible completely for IVF treatment, we can definitely do some of the initial investigations and things for you. So I would have a discussion with your GP just to clarify that. And that would be well within the guidance within primary care and secondary care for an urgent referral.
Thank you. Realistically, how long is the wait if endometriosis is discovered and needs to be treated to be able to conceive? Because I am in Bridgend and the wait for laparoscopy for endometriosis is 4 years, is it any faster if I were also referred for fertility treatment?
Okay, so it really depends on the scope of the endometriosis and what else is going on. We know, generally speaking, if you've got a small amount of endometriosis, or a small amount endometrioma, which is a little cyst on the ovary, which is full of endometriosis, then it may be that it's more suitable to refer you for IVF treatment. The caveat to that is you may be referred back if it feels like either the cyst has grown a bit bigger, or sometimes the endometriosis has got a bit worse. If you've got very severe endometriosis, it can sometimes be a bit of a trickier one, because exactly as you've said, there's a very long wait for surgery. As far as I'm aware, that's throughout all of Wales and throughout all of the UK, unfortunately. We have a consultant who works in Bridgend, both in the fertility clinic and in WFI. So I'm not sure whether you've seen them yet, but if not, I would be asking to be referred to them just for a bit of clarification. Yeah.
Thank you. And from the same person then, what is the difference in waiting time between routine and urgent wait list? Sorry for the repeated questions about waiting. It's just really important when trying to conceive and would determine whether it's worth taking out a loan to go private because time is crucial.
Gosh, yeah, it's so stressful, isn't it? It's really different between different health boards. As I've said, I only work in Cardiff. Off the top of my head, I think our routine waiting list is about 6 months at the moment. So if you can try and get some of those primary investigations, so things like the semen analysis and the blood tests, that's really helpful. So obviously there's a bit of a wait to see us in clinic, but when we see you, we've got that information ready. But yeah, it's different from different health boards. So yeah, difficult for me to say really. What I should have said at the beginning is today I haven't spoken about any what we'd call fertility preservation. So if any patients have got cancer, this isn't the scope of this talk. They would be seen on a separate pathway. Or if any patients are undergoing fertility preservation, if they're thinking about gender reassignment, anything like that, again, they're seen on a different pathway.
Thank you. How many cycles would you get with the NHS if you have an artificial insemination?
So that would be IUI. So I think that would be, I think it's up to 6 cycles, but it may be, we need to double check that. It may be if you weren't successful with those ones, that your consultant would be having a little chat with you about whether IVF may be more appropriate. So that would be a discussion to have together, basically.
And often, am I right in that you're still able to access your full IVF entitlement despite undergoing the IUI first?
I think so. I think it depends a little bit on your personal circumstances, why you're needing the IUI or the IVF. So yeah, I think that would be quite specific to the patients then.
Lovely, thank you. If you have had private testing, for example, a fertility MOT, can those tests be used to bypass the hospital test for an urgent referral? And could the private consultant make that referral for WFI?
Yes to both of those things. As far as I'm aware, the only thing we may need to repeat would be a semen analysis. So some of the, and this is something worth looking at, some of the private semen analyses don't do a test which is called a MAR test, which is it's kind of like a test for how well the sperm and the egg would get on together. So sometimes we would need to repeat that within the NHS to decide whether you'd need IVF or ICSI treatment. But yes, as long as they are within probably about 3 to 6 months, that should be absolutely fine.
Thank you. When you say self-funded egg donors, do you mean that we'd have to pay for the whole IVF cycle privately for access to egg banks? Roughly how much would it cost for an IVF cycle with donor egg from a bank? Thank you.
So I don't work in the private sector. My understanding is I think there's only one private IVF unit in Cardiff or in Wales, which do have an egg bank. And my understanding is there's quite a wait for that as well. So again, like I said, I haven't got any conflicts of interest. Some patients may choose to go abroad for egg donation, as the rules with confidentiality and not confidentiality, but remaining anonymous are slightly different. And I understand that the cycles out there are slightly cheaper as well. The time when I was working at WFI, we didn't have anyone who opted to have any private donor egg treatment, so I'm not 100% sure. So that would be something to inquire with WFI with their general inquiries. Sorry about that.
That's okay. But if they're able to source their own egg donor,
Yeah.
then the IVF would still be the treatment
Yes.
cycle would still be on the NHS.
So I
wouldn't it?
did treat some couples who they had a family member or a friend who we were able to treat. So yeah.
Thank you.
But I can't remember whether I said there's quite a strict criteria within that. So again, the BMI, the age, those sorts of things would need to be applicable as well.
Thank you. I've had a private hysteroscopy for removal of a fibroid before I started trying to conceive. I'm now at the hospital stage of the process and have had a HSG. I've been offered a further hysteroscopy or onward referral for ART. Is it best to have more investigations at this stage or get on the waiting list for WFI?
Depending on where you are, I would have a little chat with your consultant. So sometimes we can, if it's more of an urgent situation, I would list you for both. So I'd pop you on the waiting list for a hysteroscopy and refer you. I wonder, again, I'm not able to give any specific medical advice, but sometimes on a HSG, there can be a suggestion of a fibroid or a polyp inside the womb. And if that is the case, then sometimes if we refer you to IVF, they refer you back for basically for a hysteroscopy. So when you go ahead, hopefully with an embryo transfer, the inside of the womb is the best environment for an embryo to grow without any polyps or fibroids.
Thank you. You said that some patients choose to go down the private route to investigate their fertility. If patients have had ovulation induction without any luck with any one of the medication, would you likely need to repeat this treatment on the NHS route, or would you consider going straight to the WFI referral?
Yeah, so that's just a discussion we'd have with the couple about their preferences, how likely we think things are to work. Some of the medications, so clomiphene in particular, but we also extrapolate that to letrozole, is if you're using it for a very long time, so for over a year, there can be a increased risk of cysts within the ovaries, which can cause problems. So I think if you've had a good trial of Clomid already, it would be something we'd have a discussion about if it wasn't effective before, and about the risks associated with that. Some patients, if they have conditions such as polycystic ovarian syndrome, and that's why they're not ovulating. Some of these medications can also increase the risk of twin or triplet pregnancies, which obviously carry increased risks to mothers and babies. So again, it's just a good discussion point between you and your consultant about what the best things are for you as an individual or as a couple. There's no absolutes, basically.
Thank you. We live in Monmouthshire, so very near the England border. Would you be able to take NHS funding to an England clinic that accepts NHS patients? Don't worry if you don't know the answer.
I don't think you can. I would double check. I think if you're in Monmouth, you would come under an
Iron Bevan. Yeah.
Yeah, so I would double check with them. But again, I did see patients who lived in Monmouth when I was in WFI, so I don't think so, unfortunately. But it would be something I would double check with them.
Thank you. Do WFI see people who are potentially perimenopausal at the age of 35?
So we would see you in clinic first, and we would do some of those investigations. Some of those would include, as I've said, we'd have a little look at the ovaries on the ultrasound, and some hormonal blood tests, which we'd want to check if you felt like you were going through an earlier menopause as well. It depends on the results, basically. So sometimes you would then be sent as an urgent referral, or sometimes if it looks like you have gone through early menopause, the chances, unfortunately, of IVF working are very small. So generally speaking, you wouldn't be accepted then. But again, it would depend on those individual tests and results, and us having a discussion with you. Sometimes, if it's not completely black and white, we would refer you, but with the caveat that the referral may not be accepted.
Thank you. We've done lots of tests through our GP and some privately, but some of these are now near a year old due to the waiting list. Would we need to repeat tests, e.g. the sperm analysis and ovarian reserve?
It generally speaking, probably yes. So some of those we can do for you in clinic. I know in an iron Bevan, before you are seen, they will ask for those tests to be repeated anyway. But yeah, I think if it's about a year, generally speaking, we would ask for those to be repeated, or we can request those in clinic for you.
Thank you. If you have been referred to WFI after low sperm count and are awaiting initial investigations, how long would it take for treatment to start after these are completed?
So depending on the results of the semen analysis, generally speaking, it may be at that point you are referred to see the urologist. I'm not sure if you've seen them already, just to see if there's anything they think they can suggest to optimize the quality or the amount of sperm there, or if there's anything else that they need to double check, because very rarely a low sperm count can be a sign of other conditions. Usually once you are, there can be a little bit of a wait to be seen at WFI, but usually once you are there, things move fairly quickly.
Thank you. I've just had a laparoscopy privately to remove endometriosis. I'm on a waiting list for Singleton since September last year. No date for an appointment yet. Will I be seen at WFI? We've been trying to conceive for a year and a half. Thank you.
Generally speaking, if you've had private treatment, if it's appropriate, you could ask your private surgeon to refer you to WFI if they feel that is necessary. What are we able just to clarify? So I think this person hasn't been seen in secondary care yet.
No, they're on a waiting list for Singleton, they say.
Yeah. So if your GP wouldn't be able to refer you straight to WFI. You would still need to be seen either in secondary care and referred, or through your private surgeon and referred.
Thank you. My husband had a sperm analysis which came back normal but with low morphology. Is there any way of improving this?
Yes, sorry, another thing I should have said. Lifestyle things we would recommend generally, not particularly with morphology, but again, no smoking, avoiding tight underwear. And also there are some supplements which have good evidence. So they're I'm reluctant to name any of them today, so I don't want to endorse any particular brands, but that would be a male conception supplement, basically. And then usually it takes about 3 months for this new sperm to regenerate. So I would try those new things for about 3 months, and then you could ask for a repeat semen analysis. But it's reassuring, everything else is normal.
Thank you. A similar question, but I'm going to ask just in case there's more to add to the answer. So, as the male partner, age 36, what could I take to increase sperm count and better, healthier sperm for better count?
Yeah, those same things again. So lifestyle measures. We don't know the effect of vaping yet. And just to be mindful of things like passive smoking as well, and those supplements as well, and just to go and see your GP again very occasionally. If you are taking medications for other conditions, they can affect your sperm count, or it can be a sign of an underlying condition, rarely.
Thank you. If you have the private test done and issues were identified, how does the private consultant make the referral, or can I take my results back to my GP for them to make an urgent referral straight to WFI?
Both of those, generally speaking, I don't think the GPs can refer straight to WFI. They would still need to come to secondary care. The reason for that is within WFI, they don't do those other investigations which I spoke about. So the tubal checks, the operations, if you need a laparoscopy, a hysteroscopy. So it's just to try and streamline the process, basically.
Lovely. With regards then to the private consultant making the referral, they've sort of offered a supplementary comment, which is because the private consultant I spoke to at Wherndale in Carmarthenshire said he had been unable to make the referral.
I'm unable to comment about that. I do know we've had referrals from private consultants before. So yeah, I wouldn't be able to speak about particular consultants, but often we would get those.
Thank you. And then we've just had one last question, which I think is a supplementary question to a previous one. So when you talk about secondary care, do you mean a waiting list for singleton, for example? So I think that was the person who asked that they just had the laparoscopy privately to remove endometriosis, and
Yes.
that they're on the waiting
So
list. So that's what
yes.
we mean, isn't it?
Yeah.
Yeah.
So that would be that bit to check the tubes, check your blood tests, things like that. Yeah.
Thank you. We've come to the end of the questions. So, Dr. Ramcharn, thank you so much. Thank you for sharing, like I've said already, your expertise and knowledge in such a compassionate way. We really appreciate it.
Oh, thank you so much, Beth. And it's been an absolute pleasure to talk to everyone. Sorry I couldn't answer all of the questions, but there's a bit of food for thought there. So I'll go away and have
Lovely.
a still think about those things.
Thank you, everyone. As I've said, we've recorded this, so we'll pop it on our YouTube channel. We'll share it on our Facebook page, Fertility Network UK Wales. So if you follow us, keep a lookout, and then we'll share the link there just in case you want to watch this back again at a later date. But thank you, everyone, and good night.
Perfect. Thank you. Good night.